From CBS 47 and Fox 30, you're watching This Week in the 904.
As you consider your health early in this new year, are you also making sure to do your monthly checks? When it comes to breast cancer, knowing your risk, even if you are a man, is an important part of staying on top of your breast health. Thanks for joining us for This Week in the 904. I'm your host this week, Chandler Morgan. Action News Jax has worked closely with Pink Ribbon Jax, which provides local free mammograms and breast imaging initiatives. And this morning, we have Marica Pendjer with Pink Ribbon Jax here in the studio, as well as a doctor as well we'll be meeting with later on. Thank you for being here.
Thank you, Chandler. Always love my time with you.
Yes, exactly. We've collaborated a lot, and part of the collaboration is we talk about early detection all the time. Can you just stress the importance to us of what that means?
It's key, and Dr. Pearson will talk about this when she comes on with you, but when caught early, breast cancer is about 99% treatable, which means survivable. It is not a death sentence. Just please get screened.
And so part of that means you have to take action. You have to take the initiative to go get that screen. And I mentioned it at the top of the show too, but this is not just for women, this is for men too.
And get breast cancer too. Not at the same rates that women do. The statistic is 1 in 8 women will get breast cancer during her lifetime. And the stat for men is 1 in 726. So not as alarming, but not insignificant.
And when we talk about going to get your scans, your checks, and your imaging services, what is a way that you can do that? And is it you call? Is it you try to make an appointment? Sometimes it's not that easy for everybody, that you've learned.
Well, absolutely. If you don't have insurance, you absolutely need a doctor's order to get a mammogram. They usually start mammogram at 40, but you need to know your risk. That's the most important part of this. Know your risk. If your mother or aunt or a first-degree relative got breast cancer at 42, you're eligible for a mammogram at 32. You need to know your risk. You may have to start earlier. If you're at average risk, then you're okay starting at 40. But you need to do your monthly self-breast exams to know if there are any changes that you can report to your doctor.
And for you, you've seen the impact that this has. I mean, we've talked about it several times when we've done events with Pink Ribbon Jax and collaborations. And we always ask people, who here has been impacted by breast cancer? And everybody pretty much raises their hand because they know somebody or it's in their family history. And you're a part of that as well.
Absolutely. We're back to the 1 in 8 stat. I think we all know 8 women. And I find the more you're around it, the more people talk to you about it. You may have coworkers, distant family members that don't talk about it, but when they're in a comfortable setting, I'll hear from people, my mother had breast cancer, I had breast cancer several years ago. That people will open up to you, and I personally don't know anyone who hasn't been somehow touched by this disease. I call it a thief.
It is.
Because sometimes it takes days, months, years, and lives away from the people we love.
It's important to get those checks, and especially when you can, to make those efforts. What does Pink Ribbon Jax do to make sure that people can have those types of imaging services and mammograms?
Well, we're an all-volunteer nonprofit. For the last 5 years, we're actually going to be celebrating our 20th anniversary, but 18 months in IRS years, we became our own nonprofit about 18 months ago. And we have been strictly focused on raising funds to provide free mammograms and breast imaging services. And at the top of this year, our board also decided we need to also cover biopsies on a case-by-case basis. If there are no other options, we will find a way. And what sets our initiative apart from others is we are not age qualified or income qualified. By that I mean a lot of programs, especially federal programs that offer free services, start at age 40. Well, that doesn't help you if you're 27. Dr. Pearson and I worked with a patient who was 21, found lumps in both breasts, a family history, no job, no insurance, no car. And I connected her with Dr. Pearson, and it turned out not to be cancer. That was a wonderful way to start our relationship. That was our first client, our first patient together. And so she called around, and no one could help her because she didn't fit their parameters. We don't have those parameters. If you need help, we're here.
What a blessing to hear about that woman too, that wasn't the case. But oftentimes you hear too of people just I guess the best way to describe it is being selfless, but they end up neglecting themselves because they don't want to get their checks because they say, oh, there's something else that I need to prioritize monetary wise. And it sounds like you help those people too, who just, maybe they've got so much on their plate, but they really do need to go and check.
Absolutely. Through advocacy and education, we're always out there promoting this kind of awareness and do yourself breast exams. You've helped us out with the National Feel It on the First initiative, where you've actually done PSAs and put that on the air to help people remember to do those things. And one of the reasons I'm so passionate is women seem to take care of everyone first and themselves last. And we want to make sure that we are rooting her on, that we are helping her be her own advocate and making sure she takes care of herself so that she can take care of others.
And there's ways that you can find out about events to support through Pink Ribbon Jacks online, and you are constantly posting on social media too. It's an easy way to connect there. We do have a doctor, a radiologist in the studio with us this morning. So coming up, we are bringing her in to talk about developments in breast imaging.
From CBS 47 and Fox 30, you're watching This Week in the 904.
Welcome back. I'm joined by Dr. Catherine Pearson, who is the founder and director of Boutique Breast Imaging. And you were talking about your specialty as a radiologist too. That's very important, what you were pointing out earlier. How do you describe that?
So there are very different specialties in radiology, and one becomes a board certified radiologist after 4 years of training on top of an internship. But then after that, I subspecialized in just breast imaging. And so I did additional 1.5 years of training of just breast imaging fellowship training. So I am a breast doctor, so to speak, and this is my subspecialty, and this is all I do.
And I mean, you were talking about it this morning. You were reading through mammograms this morning. This has really been your life commitment. I want to talk about beyond, just your extensive, experience. You have your own personal experience and personal story when it comes to decisions you have made in your family history. Can you share a little bit about that?
Certainly, and thank you for having me. I really feel that I was put on earth here by God to do what I'm doing, and it started way back with my family, going back 3 generations. I had my great-grandmother, grandmother, mother, and 3 aunts, all affected by breast cancer. I watched the whole historical improvements through that time with the advent of screening and certainly different ways of treating cancer. And so when I was in my training at UC San Francisco, I was told I had an 85% lifetime risk of developing breast cancer myself. And what do you do with that kind of information? You could either get really scared or you could learn everything you possibly can about it. And that's what I did. So that's when I decided to be a breast imaging radiologist. I did the fellowship training. This is where I decided I was going to put my passion and compassion for women and taking care of them. And I started screening myself at age 30, which is per the guidelines. If I had had genetic testing at that time, although this was in California where there was considered a pre-existing condition in the 90s. So I did not do that. They just started me at 30. And I ended up having an MRI screening, which is what one does with high risk. When they have greater than 20% lifetime risk, they have the mammograms alternating with an MRI 6 months later. And my MRI in my mid-40s showed the early signs of breast cancer. And so I fortunately just went straight for the downgrade followed by the upgrade, and no need for any chemotherapy. And I feel like I've been on both sides of the story in terms of helping women. I can understand. I certainly have, been there with family members and then my own personal stories. So hopefully that helps with my treatment and diagnosis and care of my patients.
And understanding and being able to relate to them, in choosing in your specific instance to go ahead and then take the leap and have that surgery. And that's a life change. I mean, that's a commitment right there that you're already saying that, you want to go ahead and be proactive really. How difficult is it for somebody to know what's right for them in those scenarios where maybe you do carry the genetic marker and you just want to go ahead and be proactive?
Well, let me just first say that most women who have breast cancer do not have the genetic markers. Only about 6 to 10% of women that are diagnosed with cancer have a genetic mutation. We only test for about 13 of them, and there are 76 breast cancer genes that we don't test for routinely. But those women certainly undergo screening, additional screening with mammograms every year and MRI. They may start their MRIs at 25 and then mammograms at 30 if they are known to have a BRCA1 or 2 mutation. But then once they have a breast cancer diagnosis, or whether or not they proactively or prophylactically, we call it, want to undergo additional surgery, I think it's a very personal choice. And I think what one needs to do is look at how difficult is it to follow that patient on a mammogram or MRI. Are they a very complicated, dense-breasted, lots of stuff going on, lots of biopsies, lots of uncertainty? Do they have a high level of anxiety? Are they very fearful? I have my nervous Nellies, and I have my other patients that really just give it to God. Mm-hmm. I think we can do kind of a midline in the middle of that where we assess what they need, and they can go through a discussion with their family and their doctor about what would be best for them. I know for me it was great, and I look better than I did before, and I'll look this way when I'm 80. But there are so many amazing treatments these days that if we can just do surgery without needing any of the toxic chemotherapy, that's my goal for women.
And one of the ways that you even start this journey is by getting, imaging services. What are your standard imaging services? In a moment, we're going to talk about those who have dense breasts and what that looks like for them. But what would kind of the baseline be?
So a baseline recommendation is that between the ages of 25 and 30, one undergoes a risk assessment through their physician or a breast imaging center. And they can actually get online and do a calculated risk assessment with their family history and previous history of biopsies or funny looking cells and whatnot. If they test greater than 20% and or they have a strong family history of breast cancer, the NCCN guidelines recommend you start a mammogram 10 years prior to the age of diagnosis in that relative. So if, as Marica said earlier, if the woman is 42, and is the mother, then with breast cancer, then the daughter would start screening at age 32. Of course, if she were 23, 26 years old and went through genetic testing because she had a strong family history, or the primary index cancer case tested positive for genetics, mutation that is, then they would start at age 25 with MRI and then mammograms yearly at 30. Other than that, if they're not high risk, the average normal risk patient should begin screening mammograms at the age of 40 with 2D, 3D technology, and that is the most effective form for detecting early breast cancer. If we detect breast cancer on a screening mammogram, it's 96% curable, and that's really what I want women to take home, is that this is not one of those bad cancers. If they catch it early, if they are cognizant of what their breast exam feels like and know what their normal lumpiness feels like, then in between those yearly mammograms, they can detect an early lump that may feel hard, irregular, like a rock or a walnut, usually not tender. 98% of cancers are not tender. But if they detect something early, then they'll bring it to us early. And then those younger women who don't quite fit the high-risk category that are under 40, if they just get to know what their normal breast tissue feels like, then really, truly, when they pick it up, we usually, 90% of the time, it's curable then.
More with Dr. Pearson coming up in just moments.
From CBS 47 and Fox 30, you're watching This Week in the 904.
Welcome back. We are here with Dr. Pearson, who is telling us a lot about different imaging and advancement services and such. We were just talking about the baseline for getting mammograms and different imaging services. But there is something very specific for women the need to be aware of if you have a certain type of breast. What is that?
So women's breast tissue is about as different from one another as our faces are. It has components of glandular tissue that makes milk when you're having a baby, as well as what is hormonally stimulated. And then it has fat tissue and ligaments. The amount of glandular tissue, that white tissue, determines whether or not they have dense breasts. And if they do have dense breasts, it has a twofold meaning in that it, one, makes it a little more difficult for us to pick up early cancer, early small white cancers amidst that dense white tissue. And then 2, it does increase their overall risk for breast cancer. So someone who has a really, really white, dense breast has about a 2.5 times risk of someone, that is for breast cancer, as someone who has just fat tissue density, which is gray tissue that I can look very easily through and see a small white cancer develop. So what that means is that screening mammograms in women that are very dense breasted may not be enough. Of course, screening mammograms still pick up the early stage 0 breast cancers oftentimes that we can't pick up with other modalities. But when someone has a dense breast, which occurs in about 44 to 47% of women, i.e. it is normal, it just is part of your genetics, we may want to offer additional supplemental screening. That means something other than a mammogram, along the lines of either a breast ultrasound or a breast MRI with a contrast dye in the vein to pick up the earliest form of breast cancer. One is basically relegated to these different modalities depending on their risk. If they have a greater than 20% lifetime risk, then MRI is the gold standard and is covered by the insurance companies. The problem is for women who have an intermediate risk or an average risk, who may have extremely dense breast tissue, and we have a hard time seeing through it with a mammogram, and we would like to offer either a supplemental screening ultrasound or an abbreviated breast MRI, both of which are covered by insurance companies in 33 other states, thanks to densebreastinfo.org, which has done a wonderful job of educating women about the need for additional imaging. But the problem is in Florida, we're behind the times in terms of being able to have that additional imaging, which is needed, actually covered by the insurance companies. So right now there is a Find It Early Act that is a bipartisan act going through Congress that's been put up by congressmen from both sides, as well as Katie Couric, and they are trying to make it a national standard that insurance companies cover all screening and all diagnostics for breast imaging. And that's so important because those women who have a screening exam may be called back by the radiologist for a questionable abnormality, and that happens in about 5 to 10% of the cases, and that's usually still benign. 95% of the time it's not cancer. But then that patient has to undergo additional testing that comes out of her deductible or her pocket, and she may not go through that testing, or may get scared off and not come back for the mammogram, or she may just have a screening exam with dense breast tissue, and we can't see the small white cancer unless we do additional ultrasound. And those are modalities that we offer and hope that patients can cover that, but it should be covered, in my opinion.
It sounds like, too, that there's some cases where, you know, they're left in flux, basically. They might know this information, they might know that there needs to be a next step, but, you know, financial reason or even maybe just personal choice, they don't come back. But you're saying that it would make it so much easier if the next step were covered.
Correct. And we do what we do with 3D imaging. We have 2D and 3D mammograms where we have these thin-cut 3D images that march through this dense breast tissue and are really, really good at picking up small, and I always show this to the patients, a small, ugly snowman in the middle of their dense snowstorm. And those 3D images also help with trying to discern whether or not something is an abnormality or not. So those questionable areas, it helps. It reduces the callbacks. But beyond that, it is in some patients really helpful to have an additional ultrasound, be it either a handheld breast screening ultrasound, which we do in our boutique breast imaging center with a technologist with 20 years of experience, and then myself with 30 years of experience. And we really do detect very, very early small cancers. And the MRI is obviously the gold standard, but it is very difficult for access. Of course, it requires an IV. Some patients feel very claustrophobic inside that big magnet. And so it's difficult for those patients to go through that as a regular screening process.
And with the last minute that we have here too, I want to give you a chance to also share just the overall encompassing services that you all do provide, specifically with boutique breast imaging.
Well, thank you. So I have practiced here in Jacksonville for 27 years, and I have had the most amount of fun taking care of women the way I would like to take care of women, which is, you know, a physician-controlled environment where the patients come in for a screening mammogram. I get to tell them their results right away. Literally, they're sitting in the chair for maybe a minute or two. I go over those results. I show them their images. We talk about their personalized risk, what kind of screening they need, whether or not they have dense breast tissue, how I look at this exam, how to do a self-breast exam, what about their hormones, and they walk out of there knowing the results right then and there. And I think that that's really the gift to women right now, is there's so much anxiety around breast cancer. If they just know that we're picking it up early and they're getting the results right away without a lot of anxiety, it really does help. If there is something abnormal, I take care of it right then and there, usually with an ultrasound and or a diagnostic mammogram. God forbid it looks scary, we actually do the biopsy and have a diagnosis within the next 1 or 2 days.
Well, Dr. Pearson, thank you so much for being here with us. We really appreciate all the knowledge and the experience that you bring and the work that you're doing here in Jacksonville as well. And a big thank you to Pink Ribbon Jax, who was with us here earlier in the show as well. We have many more conversations for you on This Week in the 904 and the tab on actionnewsjax.com.
Thanks for watching This Week in the 904.